Well, welcome everyone. We'll go ahead and call this meeting to order. Welcome all. This is the regular board meeting of the Kern Valley Healthcare District. It's Wednesday, July 7th at 6 p.m. Our first order of business is approval of the agenda. And there are a couple of changes already. Under new business, item G, number 2, the Tri-Sin Secured Split Dollar Program. We had placed that on the agenda, but there will be no action on that tonight. There's still data that's necessary. So remove item 2 from new business. And we do need to add an item to the agenda, something of an urgent matter. That is a capital expenditure request. And Scott, if you could walk me through the details on adding something that didn't make the posting of the agenda. I forget what those details are.
Yeah, so you have to meet 2 criteria. One is that the issue arose subsequent to the posting of the agenda. And my understanding is this is something that came up over the weekend. And the agenda was posted Friday. And the second criteria is that it requires immediate action. And I will let Tim address that issue, though I understand that issue is met as well.
Yeah, this is our chemistry analyzer that went down over the weekend. It's 10 years old, and we've continued to have problems with it. I was on the phone with Rebecca almost all weekend long, and with the staff and with the ER doctors. We were having to transport samples to Bakersfield Memorial all weekend for the doctors, just because it's one of the most critical pieces of equipment we have in the laboratory. And so, Rebecca and I had been planning on replacing this piece of equipment anyway because of its age and so forth. But this weekend we had major problems, and the service with our current provider is disastrous at best, and Rebecca will get into the details on that. But yeah, this is something that can't wait any longer. We've got to take action on this. We were able to get that up and running. It is running at this moment, but whether it goes out tomorrow or next week or whatever, I don't know.
Okay.
So,
Scott,
So Ross,
yes.
yeah, so what you'll do is the person who makes the motion to approve the agenda will also move to add this item to the agenda based on the findings that arose subsequent to the posting of the agenda, and it requires immediate attention.
Thank you. Are there any other changes to the agenda?
No changes, but I just wanted to comment that that item is also on our capital budget for the new year. So it's not a new item.
Good.
I mean, we were aware
Great.
that it was.
that's what they were big plan for. Yeah.
Okay, I remember seeing that there. Thank you, Barbara. Did any board members have any other changes or additions, deletions from the agenda?
Nope.
Okay, and I'll entertain a motion.
I'll make a motion to approve the agenda with those changes and adding the CER requests.
Thank you, John. Do we have a second?
Second.
Thank you, Fred. Hey, we're all present. We don't have to do a voice vote. All those in favor?
Aye.
Aye. Opposed? Okay, the agenda is approved. So that brings us to the flag salute, and Director Clark will lead us in the flag salute, and our Chief Nursing Officer, Mark Gordon, will lead the invocation.
Y'all please stand, flags in the corner, right hand over your heart, pledge with me.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, everyone.
Thank you, Fred. Oh,
And for those of you who would care to remain standing, Heavenly Father, we come before you this evening for the Board of Directors meeting of the Kern Valley Healthcare District. We ask that you would bless those that could not be with us this evening. Just be with them and their loved ones. Father, we just pray for guidance, direction, right decision-making, and just make sure that the healthcare district is here for a long, long time to provide a service to the community. We ask these things in Jesus' name. Amen.
Amen. Thank you, Mark.
Yep.
Our vision statement is here on the agenda for you to peruse. Item C, public comment. This portion of the meeting is reserved for the public to address this board on matters under our jurisdiction, but not on tonight's agenda. Do we have any members of the public wishing to be heard? Okay, seeing none, we will move on to consent agenda. The consent agenda, all the items on the consent agenda will be approved in one motion unless a member of the board or a member of the public would like to have an item removed and discussed separately. All the matters on the consent agenda are considered not controversial and routine. Do we have any member of the board wishing to have a consent item removed?
I make a motion to accept it as presented
Thank you.
if we need it.
There's actually one I would like to discuss. I have to find it. It's been a couple days since I left this.
Scholarship program.
That's it, scholarship. The very last item, 36 to 41. Does any member of the public request a consent item be removed? Okay, so scholarship program application is removed. And Gene, you made a motion for the remainder?
Yes.
Okay,
I'll second.
thank you, Fred. All those in favor? Aye. Opposed? All right, consent agenda is approved. Which brings us to item E. Reports, foundation report. We have Judy Hyatt listed. I don't see her present. Are you speaking tonight, Debbie?
I am. So we're very excited. River Rhythms is definitely on. The bands have all confirmed. And we've been out getting sponsorships, and that's going really well. The health fair is a go, and I'm happy to announce today that Houchin Blood Bank is going to do a blood bank blood drive up here on the 17th. They'll be here from 9 till 1. The health fair will go till 12. So I think it's a great thing, and I'm talking to them about maybe doing something quarterly up here at the hospital.
Well, again, and just to throw in on that, the blood shortage, not only in Kern County, but statewide, nationally even, is in severe crisis. As a matter of fact, a number of hospitals are having to forego surgery because they don't have blood to do them. And so it's vital that, we do everything we can to help them out in that quest, so.
So I'm pretty excited about that. And then
What was the
regarding
date again?
September 17th, that should be a Friday. And then the foundation's currently doing an email vote regarding Sally's salad. And that is going very well. That's all I have right now.
It should be done real quick, right?
Yes. Any questions? Okay.
Thanks, Debbie. Okay, item 2, auxiliary report. Cindy Rupert.
Thank you. Well, I don't have a lot of new stuff to report. We're still only open 3 days a week, but we're doing awesome in those 3 days, getting in lots of donations. We're anxiously waiting to get started on River Rhythms. I got my boots already. And on Tuesday, I believe it's the 13th or the 14th of July, the residents from SNF are coming down for a little shopping party at 2:00 in the afternoon. If anybody wants to come, you're welcome to come and join them.
Beautiful.
And that's about all I have.
Thank you, Cindy. Dr. Finstead, medical staff report.
All right, thank you, Ross. There were 3 medical staff meetings last month. The first one was the Pharmacy and Therapeutics Committee on June 17th. We again discussed COVID-19 related issues. We also reviewed and approved a policy regarding thrombolytic administration for acute strokes. We also discussed a couple of other issues. One was the timely discharge from the emergency department and looking into ways to maybe streamline this. Mark is working on that. And he told me that earlier today that it was a breeze. Oh, maybe it was a hurricane or something.
I think I used the word arduous.
Okay, that's it. Yeah.
Yeah.
Breeze, not, we also discussed making changes in the current chaperone policy. And then we reviewed our monthly and quarterly reports, including the Critical Access Patient Safety Committee, the Medication Error Reduction Program, and medication area inspections. The Medical Executive Committee met on June 22nd. We reviewed and approved the 2 credential files that were on the agenda tonight for Drs. Baika and Dr. Matuk. We also reviewed and approved the formulary for the clinic. And then we reviewed and approved changes to a privilege form that's regarding a privilege form for belonging to the medical staff regarding telemedicine services by cardiology. This is an updated procedure from our regular cardiology privileges. We will be having telemedicine interpretation of our echocardiograms starting, I believe, Tim, this Friday or something.
Friday, correct. That's right. That was in my report. So go into a little more detail.
And we reviewed and discussed several coroner's reports. And then we also discussed updates to the COVID-19 related issues. And then the last meeting was the Emergency Department Committee on June 23rd. They reviewed the statistical reports through May of this year, also discussed the issues regarding the barriers to discharge from the ED, and reviewed their reports, including clinical quality measures, medication error reduction program, and blood culture analysis. And that's the end of my report, unless there are any questions.
Thanks, Dr. Finstead. Does any member of the board have questions?
I don't have any
Comments?
questions. Thank you.
Dr. Finstead, on the administration of the thrombolytics, is that something we're doing now? After a neurologist has a telemedicine visit with a stroke victim, is that something that can be done here?
Yes.
Yes, yes, it is. So when somebody comes in, and we have protocols that Mark has written and put in place quite a number of years ago for an acute stroke program regarding immediate assessment of the patients, determining whether they're a stroke victim. We have access to the stroke robot, a telemedicine link to a neurologist, and then after consultation, we have the ability to administer thrombolytic treatment, which is the second best treatment for acute strokes and the only one that we would have available here. The best treatment is to be at a facility where a neuroradiologist can go in with a catheter and basically snag the clot and pull it out and stuff like that. But that's not something we can do here. So really, this is basically a state-of-the-art care for acute strokes.
Yeah, it is. That's fantastic. That's really good news.
Yes, it absolutely is. I mean, and this program has been going on for a number of years. You know, and it's really a great addition to our ability to care for these really critical health issues.
Thanks, Dr. Finstead.
And that agreement was just renewed just recently. So
Okay.
with the Dignity Hospital.
Terrific. Thanks, Tim.
You're welcome.
Okay, then we'll move on to the Chief Executive Officer report. Mr. Berglund.
Okay, I got a few things for you tonight. Tesla, Southern California Edison was out this morning. They were here to inspect our Tesla battery system. Basically, we passed the inspection. We were told by SCE that they will be issuing a letter to commission the batteries. We should have that anywhere between 1 day to 1 week. It takes them to get that letter out to us. At that point in time, then Tesla will be empowered to go ahead and turn it on for us.
Okay.
And so from this point forward.
You don't have to wait for the state.
Correct.
Okay.
No, it's done. Yeah. Edison is the last piece of the puzzle on this thing. Like I said, so we're just, everything went the way it was supposed to this morning. So we were very, very pleased with that. Pleased to also report that on our payroll protection program, we received word from the from the Small Business Administration that our payroll protection plan loan had been forgiven. That will free up approximately $2.43 million for us in the district.
Can we celebrate in some way?
Yeah, we should. That's awesome.
That's great.
Yeah, as a matter of fact, and I'll get to it later, but I shared that I had a meeting with Kevin McCarthy yesterday down in his office. He got together with a couple of the CEOs to talk about COVID issues. I'll just talk about that next anyway. And the bottom line, again, I made a point of thanking him because, again, we kind of reached out a little bit, again, wondering what was happening because we got noticed by the bank that they had submitted everything to the Small Business Administration. Everything looked good from their perspective. And we just never heard anything. It was months before we got anything back. And then Barbara received a letter actually from the bank, I believe it was, that Small Business Administration had sent in. We just hadn't gotten our copy yet. That is to be forgiven. And so Kevin was very happy to see that. And there are probably only 2 of us down there that were participating in the small business loan. A number of the larger facilities had indicated because they were so big that they couldn't because there was a size limitation on that. And Kevin was kind of, what do you mean? He says, you guys could have split into individual facilities like Tehachapi and gotten SBA loans for them, but they didn't do that. They looked at everything from a corporate perspective, even though it was a carve out. They could have done that. So anyway, those of us that got it, we were very happy to have that written off. Anyway, the other thing we did receive also, we got notification from Current Health Systems that our grant that we submitted and for $161,000 had been approved. I'm going to let Mark speak to the details of that grant. He wrote it. I'm appreciative of his efforts in doing that. And I think it's something that will certainly benefit the district and the community, our patients and so forth. So I'll let him have the crack at that one. So the other thing too was there's a new piece of new effort to go out to try to get around the SB 1953 seismic requirements. And as you all probably know, SB 1953 was the law that required all hospitals in the state of California to undergo seismic retrofitting so that they would withstand a major earthquake. The thought process has changed. That was a law that was passed in the early 90s. The thought process has changed dramatically since then as a result of what's going on, especially with the pandemic and the fact that, so many of the hospitals had to mobilize people, they had to mobilize equipment, they had to mobilize people and so forth. And so the thought there is that they don't want to focus on buildings anymore. Buildings are still important to the overall aspect of that. They must stand up. But what they're focusing on, instead of the whole hospital, the effort's really going to be towards modifying the standard to only those buildings which provide post-event emergency medical services that they're available. And that would be obviously your ED, any areas for food storage, water, medical testing, things of that nature, pharmaceuticals, lab X-ray, and some OR if necessary. And so we were asked to go out and obviously do our advocacy efforts on that. And I reached out to both Devin Mathis and Shannon Grove. Actually, it also gotten a hold of Ruby Salas, only because my phone number for Shannon was, Rudy has her phone number now. So I'm telling them, thinking I'm talking to Shannon's people, and it was actually Rudy's people. So that was a little embarrassing, but they said, we get it. We got it. We'll take it to him, and I'm sure he will support that. It's a bipartisan support. Everybody is jumping on board with that one. This is going to go through as a trailer bill to the budget instead of a separate piece of legislation. And so forth. So they're trying to rep that route.
Do you know at this point what kind of price tag that has to it? Because if we're moving away from seismic, and that's not the focus, I'm sure it still needs to be complied with at some point, but what kind of price tag does this readiness have?
It should be considerably less because the bid for all of the hospitals that are left to be done is still over $100 billion statewide. And the concern there is there's a lot of areas in the state that are not in seismically active areas. And so why are we upgrading those? So kind of, yeah, exactly. And so, we've got some minor faults, but no major faults in our area. And so that was one of the things that they're hoping to be able to tackle with this as they go through and meet on it and kind of remove some of those requirements. Like I said, we still have issues, obviously, because we got a 50-year-old building that we're dealing with. But it takes away that requirement per se in some circumstances, and so that we'll see how that goes. That is expected to be voted on within the next week. That will be coming up. So
how does it look? Does it look good?
They're pretty positive about this one compared to some of the prior ones that they went through.
Is there any money involved with it?
No.
Them helping?
No, that was one of the big issues and why they're pushing for this is the fact that the state has never ponied up any money. And so you guys are putting this on the hospitals when the hospitals are just coming through pandemic, and taking significant losses and stuff like that. And so, we are, they're gravely concerned that we do something about that, and so to lessen the impact as much as we can. So we'll see how that goes. I'll keep you apprised on that. Some of the other things we talked about with Kevin, my conversations with him, was really, he wanted to know about the impact of how the hospitals were hit with COVID, and so we talked at length about that in terms of the impact of, our volumes. Obviously, the state's decision to mandate that we close, our outpatient services and so forth. Was big, and then we talked about the fact that there has been clearly, at least from my perspective, and when I made the comment and everybody kind of did a double take, I said, the issue is our labor has gone through the roof, and I brought up in some circumstances that, I've seen that they were charging over $200 for a registry nurse an hour and so forth. And, after my comments, Ken Keller from Memorial Hospital said, I want to piggyback on what Tim said is we're actually paying more than $200 an hour. And so, and we know darn well that the nurses aren't getting it. So, my comment was, this is just kind of like the gas, stations and stuff like this, just kind of gouging the public on that. And I said, that somebody really needs to take a look at that, because we're in a crisis here and they're taking advantage of that and jumping these recruitment fees up dramatically. So anyway, I don't know whether they'll go anywhere or not, but again, it kind of hit me at the right time. We talked also about the impacts on the community. I said, in my conversations with a number of business owners and stuff like that, the biggest issue they're having is being able to get people to work. Nobody wants to go to work anymore. I said, this continued emphasis of providing additional, compensation for not working is creating a major problem. I mean, and the prices that people that are businesses and small businesses, especially that are trying to reopen, they're having to pay to recruit somebody to come to work for them is just out of sight, which is ultimately going to impact the public because it's going to come through in the pricing. It has to. So I just said, something's got to be done there to try and get that over with, from at least from a federal perspective. And so, he promised he would continue to look at that. The other emphasis was put on, continued support for the reimbursement for telehealth. That had been so successful during the pandemic. A number of the health plans jumped on and were paying parity rates for telemedicine visits versus an in-person visit in the clinics and so forth, which was kind of unusual. And became primarily because Medicare decided to pay for it at that rate. So the others kind of jump on, they tend to follow what Medicare does. And so we urged him to try and continue to keep that going as long as possible. I was just reading an article earlier today that the expectation is, and the push from the health plans is to probably to lower that. They do not anticipate that it will go back to where it was before, but it'll probably be 75 to 90% of what the current rates are through Medicare. So again, we might see a little bit of reduction there, but all in all, it will be higher than it was. So, which is good.
Tim, on the nurses and the, when we're away like a year, we need so much more help.
Yeah.
We should be training a second system, a volunteer system, when it's needed.
Yeah.
With lesser requirements on them. But it's an emergency. We need them.
Well, and like I said, there with the pandemic, there were certain opportunities for hospitals that did make it easier for hospitals to get staff. You could bring nurses in from out of the state without having to have state licenses and things like that.
Around there.
Yeah, it's. I'm not aware. Mark, maybe you can correct me. Again, if you're aware, I'm not familiar with any efforts that were made with anybody volunteering their time for nursing services and those things. I mean, certainly everybody tried to call people in that used to work for them or whatever to try and see if they could come back. And
well, it's like the Good Samaritan.
And they would,
like you guys lay in the street, and unless you're a doctor, you can't touch it.
Yeah.
That's not.
The only thing I know of that they did is they offered retired nurses an incentive to come back. They didn't charge them for their licensure to renew their licenses.
Yeah.
They also offered for CNAs, they no longer have to do the full classroom assignment in person. They can do half of those hours on a distance learning module like online or something, but we're not going to go with that. I'll have a little bit of that in my report, but those were the only couple of things that I saw that even came close to, the state did forgive some of the requirements for a few of the minimum staffing ratios and things like that, but it never really affected us too much. There were very few incentives regarding staffing. They don't want anybody but a CNA taking care of residents in skilled nursing facilities, CNAs, LVNs, and RNs. So they don't want anybody below that trained level. So for volunteers, they can do certain things, but they can't feed, they can't dress, they can't walk, they can't do any of that kind of stuff. So
what if they're all infected and they die? I mean, I just, sounds pretty gross, but however, who takes over? You just leave the patients there to die, or does somebody come in that's not qualified?
See, the thing.
No, the state. I mean, there's again, the requirements are so strict in hospitals in terms of what you can do and stuff like that. So,
well, it should be more relaxed.
And the issue, there's only so much they can do.
For an emergency.
They understand.
Start telephoning people and you transfer them out.
You transfer them
Just
out.
like they would, if there was any emergency, like with the fires.
Right.
You start making arrangements.
Well, I was thinking more like the pandemic, like we just had. Everybody's affected. How do you transfer them out?
It's what you have to do.
Transfer some help in.
I'll tell you.
The regulations, you have to have certain credentialing to be able to.
Right.
That's what I'm saying. We should relax that when it's an emergency like they're talking about.
They relax it as much as they possibly could, but you still have the requirements to maintain patient safety.
Well, and that's it. Who do you want coming in and taking care of your wife or your mom? You have to have these certain standards, which are the regulations. That's why they're so strict. So
I just thank God we didn't get to that point. That's
right.
I mean,
we could have, Mark.
We could have, but again, you would do like for any type of emergency, pandemic, Earthquake, fire, you start making calls to get them transferred out.
And at the peak of this thing, this was a daily conversation. I mean, literally multiple times a day that we would get together to look at staffing issues and what are we going to do if this happens. We're looking at the patients that are being put into the units. We have enough nurses to care for them.
There were
What are we going to do?
sources through the county and through the state
Yeah, and then
could have
issues like I
gotten
said,
also.
we
We
reached
never
points-
had to request those.
Yeah, and we reached points, like I said, where we could not transfer patients out of here. We were calling everywhere. I mean, we had a couple of patients that we sent to Reno, Nevada. That was the closest place we could find to accept a patient. But that's what you got to do. I mean, if you don't have the staff to take care of them, you have to still follow the laws, again, because they're there to protect the patients and the community and stuff like that.
During a pandemic, there's no safety valve. There's not like mutual aid that you can rely on.
Yeah.
All the resources get used up. There was a call out to the Medical Reserve Corps early on during the pandemic.
Yeah.
Looking for volunteers to serve in New York and some of the hot spots in the nation.
Yeah.
And there were hardly anybody that stood up and said, I want to go, because there's no vaccine at that point.
Yeah.
Most of the volunteers are elderly, which are going to be susceptible to the disease. So the whole volunteer program kind of collapsed on itself because they're putting themselves at risk.
But if we made ourselves a little more ready for that emergency where we have to use them, if we had a system set up. But at any rate, sorry.
Yeah, no problem. Just again, I think I mentioned at one of the other meetings, but we did receive a check from Health Net for their portion of the Medi-Cal IGT. That was approximately $2,864,000. That was on top of the $1,868,000 that we got from Current Health Systems. And so again, the IGT money is coming very strong this year and so forth. So, and then obviously to get the PPP money on top of that, was great for us. So cash wise, things are looking great.
I totaled it up.
Yeah.
It's over $7 million in the last 60 days.
Yeah, Barbara's gonna have
Barbara's
reporting in June.
Some of it hit July, not June.
Oh, is that right? Yeah. But there should be some still in June, but.
We should put more days in a month in.
Anyway, we're doing good. Again, I think Dr. Finstead talked about this briefly. We are in the process of changing over our radiology company. Regional Imaging will be starting. They are technically supposed to start on as of midnight this coming Sunday. The old contract with Kern Radiology ends at 11:59 on Saturday. And so we are planning to actually do a soft cut over to them tomorrow. And then we will do a hard cut over for everything on Friday. We don't want to wait till the weekend to do that. Staff have been working pretty hard, radiology staff as well as IT staff, testing patients, sending reports across, sending images across both ways, make sure that all of those things are working properly. Again, I think that we're going to see hopefully a very good response and much quicker response time on our X-ray results. I know Dr. Finstead's anxiously awaiting that, as well as some of the other physicians, especially in the ER. And so anyway, that's in process. And again, we didn't want to wait to the last minute on the cutover and stuff like that, but we've been testing away. And so that's proceeding. And then the last thing I just wanted to bring up was that I really wanted to do a shout out to our activities committee here. They put on a party on the front lawn of the hospital for the staff and did a remarkable job. I mean, it was a lot of fun. They had all kinds of food there, hot dogs, hamburgers, even healthy ones. And cotton candy, popcorn. Someone bought a popcorn machine and stuff like this. So, and it was great. And I kind of commented this to the staff. I said it was fabulous to just be able to sit down and eat together and just kind of share and have a good time and laugh, and we haven't done that in a long time. And I think it was great for morale. So I really wanted to thank them for their efforts, and we said hopefully we'll be doing a lot more of these. So they've got a lot of different.
Sigh of relief.
It kind of was. I mean, it really was. It was palpable, so.
That's nice.
I mean, they had a hula hoop contest going on, and, which some of us chose not to participate in. And you kind of have to have hips to do that. I said, once you have more stomach than hips, it doesn't go anywhere but down. So anyway, that was fun. They had cornhole out there, things to toss, corn toss. That was going on. It was a nice day. And so that's my report.
Thanks, Tim.
You're
Any
welcome.
questions for Tim?
Yes, sir.
Okay. Then we're to number 5, Chief Nursing Officer report. Mr. Gordon.
Good evening, everyone. Thank you. Once again, I wanted to report that our positivity rate for COVID through the emergency room has been around since October through the month of June was 1.9%. The month of June, we had an uptick of about 2.1%, but nothing drastic. And July, there has not been any positives through the ER. We do have modified visitor restrictions in place. Each admission is basically evaluated by the physician and granted or not based on clinical findings and the history of vaccination status of the patients and the visitors. So we try to accommodate everyone, but if there's a real suspicion that somebody might have COVID, we put them in the COVID rooms and we don't allow visitors until that PCR test comes back. So as Tim mentioned, our grant was approved to fund 2 vehicles and 2 FTEs. The grant was written to provide a transportation service to community members who couldn't get to doctor's appointments, couldn't get to pharmacies, couldn't get rides home from the hospital after they're discharged, couldn't get to the physical therapy appointments, couldn't get to a lot of things. So what we've decided to do, we're going to try to put that under the outpatient services department. And there is money to be, I think there's a way to bill for these services. Barbara might be able to better talk about that. But once we get through the first year of the grant, I think that this will be a good service to the community. We do plan on purchasing 1 wheelchair accessible van, kind of like the one we have already, and then 1 kind of a mid-size car like a Subaru Forester or Toyota or RAV4 or something easy to get in and out of, something that can carry a wheelchair if the person doesn't need to be in it, those kind of things. So we're doing a lot of research to try to figure out what's the best way to go with that. And the other thing is we got to know systems wants in there what's required of us from current health system standpoint. We haven't seen those documents yet. As Tim mentioned, registered nurses are woefully short still across the country, and staffing agencies are still trying to provide good nurses at competitive rates. However, that COVID market has driven the rates to exorbitant numbers, as Tim mentioned. So we are now getting kind of back on our feet from last month. We had quite a shortage of nurses. So it was tough going for a while. Then again, on Saturday, now we have talked about security many times. On Saturday at around 2 p.m., another assault took place against our ER, admitting staff and laboratory staff. Not to mention the doors to the entrance were broken by the guy who threw rock through them. People are becoming more and more brazen because there doesn't seem to be any accountability for their actions. I know that you guys approved, and we're probably going to be trying to enter into a contract soon to provide security services for us during off times, in the night and on weekends. And then as Deb Hess mentioned, Tiffany is looking at Sally, the salad making machine, for a healthy option for staff and visitors. Kind of excited to see that come into play. The Skilled Nursing Center did get 6 new CNAs out of the last CNA program, so we're excited to get them on board and get them working, and then try to stuff that Skilled Nursing Center with some more residents. That's a big push right now. And the next CNA program starts the last week in August. And we also have a new instructor lined up to begin. She'll be working with Donna, who's going to be retiring after this next class. That new instructor is Vanessa O'Brien. She got her DSD, and she'll be working closely with Donna to provide that CNA program. So we're excited to have her. And if there's nothing else, that's my report.
Mark, since you were talking about the salad machine, did I see an email where somebody actually used one?
Oh, Tiffany did. She actually went to Colorado. She was there visiting her folks over the weekend, and there was a hospital in Colorado. She went to the hospital.
She loved it.
She loved it. She actually took videos of the machine showing how it made the salads and everything else.
I can't wait. I can walk across the street and get salad.
I reached out. One of my former directors of one of my larger hospitals I was at is now a Western Regional Manager for Aramark. And Aramark is one of the companies that's promoting the product and so forth. And so I called her up just to kind of say, I said, I wanted to chat with, we hadn't talked a couple of years, so we got caught up. And I said, I have one other question. This is really why I called, which was to talk to you about the Sally. She said, the salad maker? And I couldn't finish it. She knew. She said, no, it's phenomenal. They have it in a couple of their hospitals. And it's through the roof, the service and the comments and stuff like that. It's, because it was interesting because, her meeting, because she's a real business type, with the return on investments and all this stuff. But she said, as soon as I told her, she says, no, we're looking to go to our foundation or the foundation auxiliary, whatever, to have this provided. No problem. This is return on investment, it's nothing. So
just everybody being able to use it is return on.
That's what she said. The nice part, it was 24 hours, availability. And
we couldn't ask for anything better.
yeah. Matter of fact, what happened as a result of that conversation, she put me onto another machine that's called Yokai, which is it's a more of an Asian hot noodles type thing, but it does teriyaki chicken bowls and all kinds of things.
We could get Chinese food.
Chinese food, absolutely. And so it's the same exact principle as Sally and so forth. But the nice part is they don't charge you for the machine as long as you buy your ingredients through them, because they are out. They have contracts through these quality companies that they want to maintain the quality of the product. And so anyway, I've got Tiffany looking at that and so forth. So there may be an opportunity for us to provide a couple of these.
I didn't mean to interrupt. I just.
Yeah, no, that was, anyway, so.
Any other questions for Mark?
Sorry, Mark, I just took over your meeting.
Thank you, Mark. Mark, I have one. On the vehicles, the $161,000 grant. There was initial talk of perhaps using these vehicles to help kick off the home health care program. Is that still in the works with these vehicles?
That's another thing that we're going to have to talk to Shannon about. The home health program is going to require staff to manage it. And I don't know, based on our ability to get staff right now, I'm not sure we can even staff a department like that. I think we're going to focus more on the original concept of what and maybe in the future, when things settle down a little bit, there may be some home health options there. The other thing that I think you're referring to was that hospital at home service that hasn't been done on the West Coast yet. It was done during the pandemic and on the East Coast, and I don't think it was ever approved in California for.
Well, that would be in a perfect world, but we talked in the strategic plan about creating another revenue source, and the home health care was something we wanted to look into. Just wondered if these vehicles could be used for that, but I guess.
And the answer is yes. Okay.
Yeah, they certainly could.
It's not just nursing. Okay. Part of the issue, one of the bigger things that it's used for is physical therapy. And we're in the process right now. We have entered into an agreement to recruit a full-time physical therapist to come with that expectation that she would be available to do these outpatient or these at-home
Right.
visits.
Right.
And so forth. So I challenged Grace to come up with a means to staff that program. So that's in process right now. They actually have identified a candidate and so forth. And so we're trying to move forward and close that deal.
Maybe we can get a driver that's a PTA.
Well, there's a thought, you know, because the part of that money is to pay for the 2 drivers for those vehicles as well. So, but anyway, yeah.
Can it be used just a little bit for drivers and all for vehicles, or is there a percentages that's required?
There's no, we haven't seen the final out letter back from Kern Health Systems yet in terms of what their requirements are going to be from a reporting perspective. You know, and so we'll have to wait and see what that says. But the plan, as Mark wrote it, I believe, was, you know, the focus was on patient transportation and, you know, getting people into the clinic if they can't get here for a visit, getting them to the pharmacy so they can get their drugs refilled. You know, to try and improve that non-compliance that we have that's due to transportation issues and so forth. And so that's really what that was all about. So, but yes, we can, those are things that we want to use that on. And we're trying to aim in that direction to get the staff ready to go for that. So,
Right. Thank you, Mark. Anything else?
That's it.
All right, thank you. Okay, and that brings us to item 6, the Chief Financial Officer report. I'm assuming, Barbara, you're sitting in for that tonight? Okay.
Assuming correctly,
Can you make it short?
yes, I will make it short. On page 16, I'm going to start there with our volumes for the month. They're pretty much, we've been pretty consistent the last few months. Average daily census on the acute was 4.2. That's acute and swing bed patients. Our average daily census in the long-term care was 49.1. That's still a bit low, but that's because of a lot of reasons. The ER visits were at 557. Last year for the same month, they were at 479, but they weren't quite as high as we expected them to be in the budget. Year to date, they're still low, and that's because of all the lack of visits we had, especially during the COVID. Outpatient visits, now those are up because a lot of the single visits for injections and for testing for COVID and that type of thing. 1,731 for the month. The clinic visits are still strong, 1,403 for the month. Primary care and 263 clinic specialty clinics. In surgery, they've been slightly busy with outpatient. They had 4 during the month and 50 scopes. So that's tending to pick up a little bit right now. Retail pharmacy filled 3,198 scripts for the month. And in the mobile van, now this is the month of May we're reporting on too. So they had 286 visits through the mobile van. Does anybody have questions on the volumes? No? No questions? Okay, if you want to go over to page 19, this is our revenue and expenses, which are driven by our visits. Revenue for the month was $9,365,000. It's under our budget, but it has been all year. The prior year, however, the same month, our revenue was $7,942,000. After our deductions and other minor revenue, our total operating revenue was $2,761,000. Our expenses have been exceeding budget, but it has a lot to do with the COVID and everything that we've had to do. $2,958,000 for the month, whereas in the prior year for the same month, it was $2,384,000. With our non-operating revenue, we ended the month of May with a loss of $92,117. And last year, we were at a loss of $298,117. Does anybody have questions or comments
So
on that?
with the loss on that, now that we've gotten the approval to hold on to the PPP money, is that something that will make up that loss for us?
Pretty much.
And then some.
And actually, there'll be an entry into June because that happened. I mean, it came to us in the month of June.
Okay.
So, yes, because if you go to the following page, our year-to-date loss is $270,557. So that will be gone in the month of June.
Which is almost $1
And
million
then-
from last year.
I mean, there'll be changes too, and just like we had last year, once the audit goes through.
Right.
And they look at everything. Does anybody have any questions? Is there anything else anybody would like to specifically review?
Enjoy the every year going from almost $1 million loss to 200,000.
Did better than Chet, almost.
Thanks, Barbara. Okay, then that brings us to item G, new business, the current propane bid. And Bob Easterday.
Yes.
You are?
Yep. So where we're at, as some of you said on some other committees have reported to, we were looking into can we save money on propane over the AmeriGas account that we have. And so I approached all of the different companies in the valley, and the only ones that came back to me was AmeriGas and Kern River Propane. Now, to refresh everybody's memory, AmeriGas, I requested them to lower their price per gallon by 20 cents. Best that I can get so far is on the phone with the person at AmeriGas saying that my computer says that your request for a reduction of 20 cents a gallon was approved. I requested a copy of our pricing contract to reflect that. When it arrived, it still had the old pricing on it. So all I have is the word of someone over the phone that our 20-cent reduction in per gallon was approved. If that's approved, then the cost from Kern River Propane and the two costs are very, very similar. There's really not any savings. If AmeriGas doesn't come through with the 20 cents a gallon, then Kern River Propane is cheaper by about 20 cents a gallon. The pricing is a little hard to understand because AmeriGas fixes the price per gallon and adds in a area index, and Kern River Propane proposes their cost of propane plus 40 cents a gallon. And so, but when you pencil it out, the two are very, very close to the same. It's, you know, do we want to go with a local firm that's here in the valley, which would be Kern River Propane, or stay with AmeriGas? We probably will not know whether our price reduction with AmeriGas is in effect until we get the next delivery. And traditionally, our first delivery for the wintertime is usually in about September. So we can either choose to go ahead and make a decision today. We could wait and see whether we do get the cost reduction from AmeriGas. That's kind of where it's at right now. I have requested Kern River Propane because all you have in your packet is a letter stating what they're proposing. I asked them to give us a contract. They've been working on it for the last 2 days. They thought they would have it to me today, but I hadn't received it as quitting time. So I'll probably have it tomorrow, which will be an actual contract that says it will be the cost, their cost per gallon plus 40 cents. So I'm waiting on that. I'm also trying to get a revised pricing contract from AmeriGas, which I've been unsuccessful so far in getting. So that's where we're at on that. So we can either move forward with making a decision this evening based on that, or we can wait. It's up to you.
Well, I think the recommendation from the finance committee was to go with Kern River.
Right.
And and not wait till September till we filled up, so.
I'm not on that committee, so
Right, okay, I mean, I just
Yeah.
understand, but I think that's the recommendation that came from Finance Committee to be on
Yeah,
here.
and like I said, and I'll just put my comments back in from that meeting, again, and looking at this, I think even with that reduction that they were proposing, the prices were still relatively competitive.
Yeah.
And, my concern obviously with the way AmeriGas was pricing their contracts was that they were locking their fuel price in, but then they fluctuated their own costs,
Right,
which are unknown to us what those are.
right,
The thing I appreciated about Kern River is, one, they've been extremely responsive, when we talk to them, that they, in fact, have locked in their costs, so that's not going to change, it's 40 cents. And then, well, the issue is whatever their gas price is that they pay, that's what's passed on to us. And that's publicly available information, so that can be monitored. And so for that reason, I strongly was leaning to the Kern River. And again, I think the fact that we've got a local person who can provide that for us, I think is certainly been in keeping with what we've tried to do, is to promote use of current, local vendors.
our community, yes.
Betcha. So that was really my reason for supporting the Kern River propane contract.
The 40 cents, as everything's increasing, the price and everything, he's eating, he might be losing money just delivering us the gas over the next 3 years. So he has us more in mind than his company.
Yeah.
And so he's an awesome person. He's been here, he's been in hospital. We've saved his life once. So the employees at AmeriGas are good. But can I make, I can make a motion that we accept Kern River Valley Propane's bid effective immediately.
Can we include in that motion authorization for Tim to sign the contract if the wording of that contract comes back and acceptable to Tim and Bob and to Scott?
And Scott, right, yeah. I was going to suggest that too.
Okay.
So
I just have a little confusion because my understanding, I thought it was coming to the consent agenda by the end of,
That was initially the plan, but because we didn't actually have an official agreement, there's nowhere on there for us to sign or for them to sign.
okay,
And we were expecting to get it yesterday or today.
So we put it on
It's gonna be a
for
new
the-
document that you
Oh,
haven't seen
okay.
yet, so that's why we put it on new business.
okay, that was just my.
So we're going to make it
was one-
conditional, that it would be conditional based upon, as Gene was
Okay.
suggesting,
Okay.
that we do that pending that the contract stipulates what's here and that it meets all of our other requirements for contracting. So that
Thank
we'll review with Scott, so.
Okay, so Gene's made that motion. Do we have a second?
I'll second. For sure.
Thank you, Fred. Any other discussion on this matter?
Well, I just have a comment. I don't have anything against the vendor, but I'm just wondering why in May, the finance committee said this is not going to be an issue until January. Everything is great, yada, yada, yada. And now here we are circling back, discussing this. Like, this is the biggest priority for the whole healthcare district. So what is the urgency, I guess?
Okay, who
You
said
got
it
a
was
full.
not a priority?
I didn't say it was a priority, but you said in the finance meeting in May that
That's because Bob,
Gene, this is the minutes from the meeting right
okay,
here.
okay,
It's on tape.
okay. And what
You
was
want me to
Bob
read it to
saying?
you?
What was Bob saying?
Wasn't Bob, it was you.
It was you that was said.
What was he saying that I wanted to get him to stop talking?
Well, I have to go back and look at the tape, but you said, you
Okay,
want me to read your statement to you?
no. It is urgent. We've been losing 20,000 a year. If you
That's
go back
fine,
and
that's
take the
fine.
40
I'm
cents.
not disagreeing with
take
you,
the
but
40
it's
cents.
how you're doing it, Gene. You're bullying the staff and you think you have some damn exclusive prerogative to just come in here and bully the hell out of everybody. There's a procedure that you take as an elected public official. If you have an issue, just say, put it on the agenda and we'll discuss it. Don't say in a meeting where you say, wait till January, like there's no issue.
Then everything gets changed. Everything, well, I gotta wait. I gotta do this. I need 90 days. I need this. It's been made confused by the process being give me 90 days, do this, do that. It's not a clear cut what we need to do.
Okay, but you still said in May, we can wait until January.
No, I did
You
not
did.
say we
You
can wait
did.
till January.
Excuse me, gentlemen.
I
Okay,
did
I
not
think we
say
just
that.
need to take a minute. Here, I asked for it to go again when
It
we
would
went to
never
June.
Say that.
Director
Because
Park, can I read him his statement? And it's on tape.
Okay.
Right, I
Go
understand
ahead and
that.
let John have the floor.
Okay,
Okay, this is from the May finance meeting.
but I would like people to have the floor and
Okay,
control, not,
I got this.
yeah, because I feel like I'm being yelled at, just
No,
not sitting here. I know, but so that's why I'm just saying, let's just take a breath and read the statement. But this is, it's tough to do. It's not personal, but it feels like it sometimes. So go ahead, John.
so you said in the finance meeting in May, under item 6, propane bids, the cost of the breakdown for propane for the last few years have been presented by Bob Easterday. Director Parks stated he was satisfied with the research that had been done and felt there was time to negotiate and perhaps make a vendor change in January if appropriate. And that's on tape.
Okay, I'd like to see it on tape. You show me. I did not, I would never say that. Okay, show me. You and I after the meeting.
Okay, so let's.
Can I make a statement?
No. Let's stick to what the issue at hand is right now. The issue is we have a motion and a second to approve an agreement with Kern River Propane. So let's resolve that business. This other issue, John, that you're bringing up is a broader issue that, the board should probably discuss
And yeah, I don't
at a
have,
later time.
okay, well, I don't have a problem with the vendor, but it just seems like there's been this,
Now who's bullying who?
oh, you're not going to put this on me, Gene. You've been doing this since you got on the board.
So let's take a vote. Let's take a vote on this matter and then we can figure out the best way to deal with this bigger issue. Maybe in closed session.
I had a motion by Jean, but I didn't hear this.
We don't have a, so Fred has a second.
Thank you.
All those in favor of the motion?
Aye.
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 Are you in favor?
I,
Any opposed? Okay. All right. There's some stuff that we need to resolve among the board and, the fact that we all care deeply about this district, I think comes out sometimes in different ways. And I think that we need to demonstrate to the public that we can work together. And I know that we can. I know that we're a good, strong team. But that doesn't mean that we're not going to get frustrated once in a while by some of the things that we deal with as a group. So, gosh, I almost hate to open this next one up, but Tim's performance goals.
You hate it.
Yeah, the Tricentennial item, as I mentioned earlier, we were waiting for numbers and we don't have them yet from underwriters, so we'll have to put this one off for another day. So proposed CEO performance goals. And I want to thank everybody for their input on this. Not only did all of you provide input in one way or another, but you did it by the deadline. So I appreciate everybody's participation in the creation of these goals. So what we have, the last page of the agenda packet are the draft goals. There's some strikeout in this. And also, I know that we want to talk about item 4, bullet point 1, that 60 days. I know that was discussed in the finance committee, and Catherine, you had concerns about that deadline. So that definitely is one thing that needs to get discussed here and resolved. Goal number 10, I don't know if everybody's seen that one yet. It was written based on input from Gene. And I don't know if this hits the mark on what you were trying to achieve. So we need to talk about that one. And then item 11, this is a new goal as well. And from input from Catherine on hitting some broader issues, this item 11 hits one of 4 of those, but one that we think we can actually control and measure and include within Tim's performance. So I don't know if you've all had a chance to review all of these.
I have.
Okay, do you want to start, Catherine?
Yeah, the question I had, and I don't know if it was a question or more of a statement that I know from the vendor packets that some of our, sorry, I put my glasses on so I can read.
I thought you were just being cool.
Well, I don't need those for that. Put that out there. Is we have made great strides in lowering, you know, the debt and being more on time with them. And that's local vendors. And I know that we have some vendors that are 45 days, 60 days. I went back and looked at the information, and I understand that some of them aren't considered late until they're 60 days. But as it being one of your goals, Tim, I think that because you have, and with Barbara definitely, and Chet made so many gains in going to the 45 days, I would just like it to see it stay at that, unless, again, but I just feel uncomfortable, I guess, saying it's not late until it's 60 days. But if we're doing well and we have a contract, should we make sure they're paid before day 60 so we're not ever considered late?
I think the issue is obviously we want to continue to try to do that. You know, I think, you know, again, we have some obviously that go longer than that.
Right.
You know, and so forth. And so I read it, or my reading into this was to really try to make sure that we handle them all that way, you know, and try to stay within those terms and so forth on an average. You know, some are going to be less than that. And so obviously, you know, where we have contractual terms, then obviously we should try to meet those, you know, unless, like I said, we've negotiated something with the vendor where they've allowed us to do that. And I think, you know, that we discussed that earlier, you know.
Right, we did.
And so, you know, that's the issue. It's you know, obviously we want to make sure we get people paid timely, you know, and but at the same time, like I said, we do have to hold money back just to make sure that, you know, again, we don't have big blips. Like I said, we've been extremely lucky this year. In the last couple of years, obviously we've had some great years financially because of some of our supplemental payments and so forth that have come forth. Which have been vital to us, obviously, in our efforts to try and do, you know, our seismic upgrades and those things, and the refurbishments. And obviously, we want to continue that. But like I said, you know, managing that accounts payable is a big process, you know, and so forth. So we want to obviously, the goal obviously puts a lot of focus on that effort to make sure that we're doing that timely and so forth. So we're not looking to move backwards from where we've been. You know,
right. And that's why I think when we put and first agreed and the goals were for 45 days, I mean, you guys have been pretty much meeting that.
Yeah, trying to, yeah.
And that's a goal for you.
Yeah.
So when you said, well, I'd rather see it go to 60 days, I don't want to see you step backwards when you're already doing better.
Not looking to try to do that. I just, like I said, I was applying it, that's what I'm saying. I think it's maybe just the way in which we were looking at it.
Well, and again,
I was looking at this from across all vendors.
Right.
And so forth, that we try to get that 60-day issue met.
Right.
And so obviously we have a bunch of those that are carrying over. So we've got some work that's got to be done to get those down. And that's what I'm looking at for this.
Right. But
so I'm not looking to say change anything that we're doing with other vendors. So that's
right.
Understood.
But a goal is always to obtain a higher level of what we're doing.
Sure.
So, and if we had previously said it, and again, it was for the local vendors, I just think it's something you can, and you guys have been working on it. Right. I would just hate to see a goal that I personally believe, I don't know as the board, that you guys are working at and obtaining it. Why lower your goals? That's my question.
I'll reach out Barbara for your input and so forth.
It's up to you now, and it doesn't, you know.
60 days is much more manageable. And
But do we always meet those 60 days? Or if we have the money, do we work on, I mean, if the board's agreeable and they want to go to 60 days, that's fine. I'm just one voice.
well, we're
but-
not going to make everybody go to 60 days is the thing.
Right, but when we say that's the goal, who cares if we can meet 45 days?
So
If we
But the
got
goal is
60,
an
And we're not
average.
looking at that from that perspective. though.
It's
but the way it's wording, that's what I would think. I could, it just, the way it's wording, I think you guys are doing a good job of what you're doing. I hate
Sure.
to see it take a step back, and that's the way I look at it.
So if we put this at 45 days, and what it's saying is if it goes beyond that, then let us know.
Then let us know.
Let us know what's going on so we
And-
understand.
Right, and yeah, this is a 60-day vendor. We've been doing it for 45 days, but we're holding money back because or you know what I'm saying? I just want a little explanation, like my husband does when he sees my checkbook, which I don't even write in.
I think,
But it was just one of those goals I thought that was obtainable, and a goal that I thought, well, if it's obtainable, why not try to continue to strive for something that the hospital's questioned on a lot, finances. And I've learned a lot being on the finance committee. Hence, I have to wear the glasses just because this is smaller font. But there you go, Walmart, I'm coming. But I just think it's something you guys can do or work towards. I just don't want to see a step backwards as a business, especially when finance is a big issue for the community. So, but if everybody's okay with it going to 60, I'm just one person.
If it's just a notice issue, I'm fine with it.
And that's pretty much what it is. I went back and looked at the ones that were 60 days and stuff. So I put it in my own little binders. I could keep my own track, like I acted like I knew what I was doing. But actually, Tim, when it comes to goals, and that's when you guys are striving at, and you're kind of doing it, why step back? That's it's like you're doing a good job. Take it and say, okay.
Doing a good job.
Right.
Like I said,
As far as the finances, and I know that.
there's a lot of different goals here. Obviously, there's a lot of work with some of these. Okay, and I've got a strategic plan that I'm trying to manage
Right.
too, and so forth. So I'm just trying to keep that in play, I think when we first started this, I think we had like 5 goals or something like that we put together just to have some to do.
Right.
And that's expanded over the last 2 years and so forth. But in the meantime.
taking 2 off the list.
I know.
Only because I asked you. And so
Maybe I'm overestimating my expectations of what you guys are capable of doing. But
No, I don't think so.
Well, then.
And I appreciate that.
But it's something I think is a goal.
Sure.
And if you can't make the 60 days, okay,
Goals
you
are-
say this is,
You have to look at how people perceive a goal. Okay. I've been in certain systems that were for-profit oriented and so forth. And if you didn't hit your goal, you're gone, and stuff like that versus something this is something.
I wasn't
allowing you-
setting you up, just in case you were
Well,
asking.
You understand sensitivity. We've all had
Right.
different work
No.
experiences.
You will be criticized by some.
Sure.
You will.
I get
Well,
criticism
I
all the
know-
time.
yeah.
So that's not a new issue.
Well,
The issue, like I said, it is something to strive for.
Right.
And I'm fine with that. That's
Yeah,
something-
and just the difference, in the reporting, which you guys are pretty much reporting anyway.
Yeah.
So it's not that big of a change. I just would, I think the process of you guys that work together to do that.
We're gonna have to
which-
create a system to how we're gonna monitor that and so forth. So.
So, you've convinced me. Number one, I'm convinced.
Well, it was your goal in the
45
first
days.
place.
But, and I don't want this to be punitive. The point of this is not to be.
No.
In my mind, what I was getting at with this was, I want to know if we're having cash flow issues. I'd like to know about it.
Right.
And I need you to manage this operation so that we can continue to pay the bills. And if we need to stretch out payments to do that, then we need to do that.
Then we
Sure.
need
I just
do it,
need to know
right.
about it.
Yeah,
We're actually
right,
doing
sure.
that.
Got it.
My only comment is, so I think right now, like, we're in a really good cash position, which is great. I mean, before, we would have to stretch it out to 60 days. And I think the only thing that I'm worried about when we're talking about days is if we eventually get back to that scenario, hopefully we don't, but where you're meeting like 30 or 45 days, you can't meet those goals and your whole cash flow is crippled. So it's like you just said.
Right. Yeah, it's not, it doesn't say, don't do it, don't exceed 60 days or don't exceed 45 days. It says, let us know it's going on.
Yeah, that's right.
Yeah.
And I can live with that.
Okay.
Yeah,
All right.
we will get, according to the last meeting, a complete vendor list with everything.
Oh, it'll compile
Recorder
together. and
Or
stuff.
monthly if we wanted it. If we felt like there's an issue, we can ask her to print it out and we can tell where everything is exactly.
Okay, and that's, I mean, I think we had talked about that before and I understand that. I just, I guess in my mind, when I read it, I just thought, we're doing it as
Yeah,
best
it's
that
got it
we
down.
can and as we can. And you guys are doing a good job at it. And
I'm yielding to you.
I think I appreciate that. It's just 60 days late. When you think the way the wording is and stuff, I'm like, I don't want to see
I
it
see your point.
60 days
Yeah.
late.
Gotcha.
Because it could have been a 30-day bill, or maybe
Correct.
it's a 90-day, so
Good
it's
point.
not really,
Good
if it's a contract for being paid for within 90 days, and we've gone 60 days past that,
That's a problem.
that's a problem.
Yeah.
So,
No, you're good. Your point's well taken.
okay.
So are we okay with that change from 60 to 45?
Yep.
Okay.
Thank you.
Then I want to skip to number 10. Now, this is a report that it doesn't sound like it's automated. Chet's been doing this, and with Chet being gone, it's not being done. I'm confident that you can recreate this report, given enough time to make it perhaps automated or turn it into a macro or something.
I don't think it can be.
I don't know, you can't automate it
Well,
no more.
the one that we just did, that you just did, the operating expenses, revenue versus, we have to make money to pay. We borrowed money. Got to start paying for it. And if we don't have income, we can't pay. It's that simple. There ain't no, we got 25, 35 million now. But once we spend that, we've got to start paying it back. And we just need to see where there's an income. And we need to figure out where how to figure it out, whether to use the IGT or how much to use, or when we get extra money in and, where we.
So- How I took your feedback on the goals was that you want to make sure that our operational costs, not all the other stuff, not all the,
Right.
not all the
Frills that we're getting free.
Yeah. not all the other money that comes to us, but on our operational costs that we're profitable.
Right.
And,
Exactly.
and so that's why I turned to this product line analysis summary.
Yeah, right.
It seemed to be
Right,
the one
right.
that is that indicator.
Okay.
Um,
But that's the goal, is to show where we're starting to come up and make money. All of us, not just on
Yeah.
Jim, but we all need to
Well,
work.
it's all of
on
us,
it.
no question about it. And all of these are. I mean, we've all got to work towards these things. Otherwise, it's not going to happen. This isn't a one-person goal. And again, I know we talk about, we got to do this without IGT and stuff like that. There's a reason hospitals get IGT.
That's right.
And that's because we see a
'Cause we
predominantly
can't do it
high,
Otherwise.
well, you get a predominantly high number of low-pay
Right.
patients coming in, Medi-Cal,
Yeah.
seniors and those kinds of things. And that's why, because the reimbursement rates aren't covering those costs in many respects.
Right.
And so therefore, there is additional money that is made available to us to offset those costs. That's the reason why when the audit comes through, the auditor puts that back into operating revenue.
Where we were set was in 93.
Yeah.
And we had clinics that were losing money. We were losing our ass. We were in deep shit.
Yeah.
Right? So that's when they came in and said, man, you guys need help. Go this side.
Mhm.
If they revisit, which they can.
Yeah.
They can come in and say, hey,
Not anymore, they
you
can't.
guys are not.
We don't have Cal Mortgage anymore. That was Cal Mortgage that came
Well,
in.
no, I'm talking about the IGT money. That's not.
Well, that IGT money just comes, it's not
Yeah, well,
subject to that. So
No, that's subject to, that was put up in 93 at a certain figure.
non-IGT didn't exist back in 93.
Okay, where's Chet?
That's not here.
Okay,
IGT just came within the last 6 years.
Yeah,
Right?
it's
Okay.
a fairly new
Okay.
program.
okay. Well, Barbara, is that IGT has only been here for 6 years?
probably. It wasn't back in 93.
No,
Well,
It's
okay,
just been the last few years.
what was it to 93 that when we had all those clinics and losing money and started up?
but the cost.
We'll have to get Chet back to tell the history.
Well, the clinics are started in the late 90s. But you're talking when it was the revenue
Yeah,
bond.
90s.
Yeah.
You're talking about the revenue bond, I think, right?
Well, no.
Was that when they did
No.
they went
It was-
self-funded for the community?
It-
Was that one of the things that caused that? Because I know they took a huge loss on that. They went at risk for.
There were like 3 or 4 clinics, and when we defaulted,
Yeah, well, the issue with the clinics, we opened the clinics up all at the same time. Craig's here. You have some of that history, don't you? You were involved with some of that stuff. Or Heidi.
Barbara knows everything. She's been here for 30 years.
Yeah.
I don't remember everything.
Yeah, we had several clinics and volumes were not great enough to support all of those clinics. So 3 ended up being certified as rural health clinics. 1 was never certified. And then we brought that down back to the single clinic that we have right now. And that was in 99 to 2000.
Okay, well, but according to Chet, listen, I wish he was there.
Yeah.
They can revisit our subsidies on IGT and revisit and see how much we need.
Well, there can always be audits done. You know, again,
Okay, all right.
was that given appropriately, stuff like that, yeah.
But meanwhile, all I'm saying is we need income. We're borrowing money and we're building it.
We don't have a say over what the IGT is.
That's
They
just,
do.
yeah, it's given
They
to us.
do.
Right. They,
Yes, that's
Right.
what I just said, but
we don't.
no, they do. They can.
No, his point
We're
is
gonna
that
cut
we
in
need to
half.
set this up so the operations run based upon what we generate ourselves.
To try to work toward it.
Yeah,
That's all.
I mean, like I said, my point was is that some of that IGT money has provided us to offset some of those shortfalls that we've gotten because of our reimbursement structures there.
And they've
So, but
changed.
can that go away? Sure, it can go
And
away.
they pulled some back 2 years later that they gave us, if you remember, right? I mean, so it's not safe money. We'll probably get it, and probably keep getting it, but
The efforts, like I said, have always been to try and create a profit. I mean, none of us like to present a
that's-
negative
that's
number
all.
on this thing.
just work toward.
You know.
Oh, I know what you're talking about, Gene. Okay, so, yeah, late 90s, there was the Balanced Budget Act, which affected Medicare reimbursement.
Right.
Okay, I got it now.
Maybe dish payments or something.
Something like that.
But
Or that was part of the issue.
we were in a really sweet spot. We were so poor that they gave us the most they could give us. So, and it stayed that way. It stayed
It had
that
to
way
be
ever
dish or
since.
something like that.
I thought we're living in a third world country.
Yeah, and Jed's was worried to death that, somebody will look at us again.
So this one is, to the extent we can make a profit on our operations. So we're introducing 2 measures, one, a gross profit, and then secondly, the net profit. And most often, we make the gross profits. When we introduce the overhead costs on some of these departments, they don't pencil out. And so if that's the case, then we're looking to Tim and to Chet and to Barbara. What do we need to be doing differently? And is it, okay, so we rely on the IGT payments because the people being served by this have a poor payer. So we need that supplement.
And if things get tough, they could pull some of that back.
Right. Then we stop
And so-
the operation.
Then we gotta.
This was the reason that we did the strategic plan, obviously, so we could go through and identify other revenue opportunities that we could start doing to get us to that position where we can rely on operations without having to worry about this other stuff. And this then becomes gravy to us. But yes, I mean, that's why we're looking at those outpatient
And with looking at that, we just.
infusion centers, and we're looking at, testing sleep labs. We're doing all kinds of things that we're studying at this point in time. So, I mean, yeah, that's really where that's going to come through. And you'll see that when it happens.
Sleep lab. You need to address that comment right now.
I was so interested in printing all this. I actually figured, I printed how to make sure my Traeger came up to 10. That's pretty good. I was like, who are we talking about here? I said we should use the OR, the surgery during the nighttime or weekends when they're not being used. Just use that as a sleep study area for a short period of time. Or until you do, or long.
Yeah, and so those are
or-
things that obviously, yeah, we'd want to run through chat because we have an
Right.
opportunity to use.
Rooms you can't do that. You can't use that space like that.
There's rules
An
against it.
operating room is designed to be an operating room. You can't use it as a sleep.
Dang it, Marcia.
Not the
that's a good
operating rooms,
idea.
but
There are certain regulations with
Well, not
respect to
operating
the
rooms, but you
surgery
have other
department.
beds in there.
Recovery.
There's the recovery rooms and stuff
Yeah.
that wouldn't be considered that could be used.
Trouble with.
I was just
But there's
trying to
still,
come
but
up
there's
with
still
something.
That would have to
requirements.
be individual rooms.
I get it. No, I get it.
You only have one person.
Well,
Just-
well, my hope if we do this.
Trying to
we
come
get
up
more-
with a way to help reduce or.
We'll bring it back to you guys.
We'll bring it back.
Out of that cost center.
But it's just an idea of where
Well,
we can't have more debt than we got money coming in.
Yeah.
We got to sort of balance it.
We all agree with that.
Okay,
We all agree.
okay,
with that.
that's my only reason
I
for
know,
that.
isn't that something that we
Forgive
just
me,
add
Barbara had
into
a
this
comment
part?
she wanted
Oh,
to.
go ahead, Barbara.
I'm sorry.
That's okay. When you were talking about the overhead costs coming in, Chet groups the revenues and expenses that are like in the ER. He adds the CT to that because all the CTs are done in the ER basically. But each department has their own report function for what they're doing. And overhead costs are the calculation of what Medicare tells us after the cost reports are done, that all the administration, dietary, housekeeping, maintenance, those costs, how much belongs in each department.
How to allocate it, right?
Yeah.
Yeah.
And so that's where those come from. So the rest of it has to be, the rest of us have to be supported by what the services we're providing.
It's basically absorbing the cost or covering the loss at one
Mhm.
department. Yeah, okay.
It's not gonna be accurate. It's just gonna make us a little more aware the way that we need to finalize it. Of, that we're going in the right direction. That's all. It's not gonna be.
I'm okay with the goal if you want to move forward.
Okay.
Okay,
Maybe
then
check
goal
that.
number 11, again, a new one,
Can I say?
is to provide focus for the organization on improving the patient satisfaction results. And this will be measured by the quarterly patient satisfaction reports we receive from ICANN. I think that's how you pronounce it.
Uh-huh. Yeah.
The goal would be to see measurable improvements in at least 3 of the metrics.
Yeah, we have a number of metrics that they monitor, and the issue there was, again, to start turning the wheel, turn the boat, on some of these things. And we'll obviously report back to the board of which 3 we pick so that we will know on an ongoing basis, we're gonna be watching these. We'll highlight those and so forth. But I think, that's one of the things, and Mark and I have had conversations about that in terms of challenging the staff to try and improve those overall patient satisfaction scores, because that goes a long way towards people's perception of the organization from a quality perspective and those things. And that's why I thought just kind of getting to the meat of what you were trying to say in there.
Yeah,
Some of those things, like I said, when I look at that in terms of the overall global cost of healthcare in our community, I don't know how to measure that, and some of the others, good things, but beyond, I think, our control to
We can't make them responsible for it.
well, right, I just didn't know, like,
Yeah.
if we have something that we know, we saw
Yeah.
45 Medicare patients, we saw 15, and did we see any Kaiser or?
Oh, she has that number.
Yeah, that's what I'm saying. When we look at what our their payer source is, what is the most ones we have here, and are we,
Medi-Cal.
Medi-Cal,
I
right.
know, I know.
You're well aware of
Vast
that, right?
majority.
I'm aware of that. I just wanted to make sure that we
Yeah.
were meeting those,
Sure.
services that any
Yeah.
payer could come here without.
Sure.
So I just didn't know what the major portion, I do.
Well, like I said, so much of
But-
that is a byproduct of the community that you serve, in terms of what we.
Well,
get.
and that's the
so
type of community
but-
we're in for
but-
retirement.
Getting to the point, again, of how do we change that metric? The point is that, if we want to have an opportunity to pick up more of that higher paying business, some of that stuff that's going down the hill, we've got to focus on our reputation. We got to focus on the quality of the services that we're providing here and people's perception of that. That's what's going to change.
and you may have given it to me and I just ignored it, but do we have, or can I get a copy of what those surveys are?
Oh, yeah, we present them. Where do those go, Mark? They don't go to the medical
Online or
staff.
something? Okay.
Yeah,
I
we'll
just
get them to
didn't
you.
know if, we had questions on there about, you know,
Those are pre-printed by CMS. Those are put out by CMS. We don't have any
Okay.
control over what's
okay.
written
And
on
so
those
do they
surveys.
cover like, the cleanliness of the room?
Yes,
or
it
the
does.
paint?
Yes.
You do all
Noise,
that?
cleanliness.
They cover
yeah,
cleanliness,
responsiveness
noise.
to Nurses, the doctors.
Okay,
Is
perfect.
that just the skilled nursing or is
No,
that
it's hospital.
all hospital?
It's hospital discharges only.
Yeah, it's the acute side.
Hospital charges?
Yeah.
Med surge only.
Yeah,
Oh, med surg.
it doesn't include the SNF. They don't do surveys for the
And
SNF.
it doesn't include ER.
Correct.
But a lot of the results of those reports are based on a patient that got admitted through the ER. They're reflecting on an experience in the ER. So there's a lot of
Yeah,
Carryover.
that's kind
And
of,
this is what we talked about is because if we're going to change those goals, we got to go to the source of the problem
Fix that ER.
and fix the ER. Correct. And the issues and people's perception of how long they're waiting in the ER and those kinds of things. And Mark's got all kinds of studies that we'll save for another day that he's monitoring length of stay in there by hours and by provider and so forth. So
so there's not one like for dietary skilled nursing or something like that?
there is something on food, I thought.
there is, yeah, and that's one of our goals to improve the food.
Yeah.
But historically, and that is on that
Sure.
survey.
You'll see.
Okay,
It's
yeah.
pretty broad,
Catherine,
but
I'll
like
get you a
I said,
copy of that survey.
Okay, that would be perfect.
Absolutely.
I just think, because when I've been in the hospital, somebody would always come around and ask me 10 questions.
That's
you know.
typically how it was done. But like I said, it was
I know we do electronic and we source it out,
correct.
but if we're not doing it for the skilled nursing, maybe we can, whether it's activity staff once every 2 months with families or.
We talked about that, again, the other thing we do, some of that is picked up in the, what's the monthly meeting we have down there, Mark? For the SNF residents meeting.
Oh, the resident council.
Yeah,
Yeah.
resident council. Those things come through there. We talk about housekeeping. We talk about food issues and they're going on if
But
things are late and
Their
our
family
quality.
members and stuff aren't in there.
No, this is the patients directly
Right.
themselves.
And so, but I'm kind of curious about what do the family members think and stuff. So,
We could certainly look at that as an opportunity because could we put something out to the families? I'm fine with doing something.
yeah,
like that.
I'm just, I know there used to be family council meetings.
Correct.
I don't know if they do or
We
not.
still do them periodically, yeah. A couple times a year.
Maybe they can send out surveys just to the family council.
Yeah, we could do that.
So
That's
I'm just
actually
kind of
a-
curious because then you get more of a,
Sure.
we talked about it in whatever meeting, maybe, but we talked about that you have managers that you don't really have to worry about because they know what to look for and what they're doing. And so they're not like micromanaged or anything. Those weren't your words. But I wonder if sometimes we get so settled in that we don't see what we should be seeing. Like someone was talking about chairs in the ER, mixed, different chairs or whatever. So, but if somebody is capable of not having to be managed so closely, they should also be able to see that there's 4 different types of chairs and get that taken care of on their own.
Yeah.
Less off of you.
Sure.
So those were just kind of my things about when you guys talked about that.
I can delegate some.
I'm not going to talk next meeting.
I appreciate your input. I really do. I value it. So
I did a survey. My neighbor across the street came in here. And they did a great job on her.
Mhm.
But the food place is awesome. Skilled nursing, everybody loves food. She said she had never had worse food in her life. She hated it. And she said the room was dim or not
Dreary.
she didn't like.
Yeah.
Now, I'm not criticizing the hospital.
That's their
and
feedback.
I know
yeah.
what we need to do,
Sure.
but maybe the food place, because we don't have a lot of patients in there.
Mhm.
Maybe the system isn't the same. And so that's something.
Need a salad machine.
Well,
Yeah.
you know what? It's hard to take the
Yep.
response
Nice.
for somebody that's sick.
Sure. Well, and that's the
You
thing,
know?
because a lot of times, and this is what doesn't get picked up in these surveys, is the fact that the patients have been on special diets.
Oh, yeah.
No salt, no sugar, no, whatever. They're bland.
Well, and they don't feel well in the first place, so
Right.
nothing's gonna be perfect.
And the trouble is, none of these surveys pick that stuff up. So
You can
Does the
open
pink
positive and
ladies-
can't
Does
taste.
the pink ladies ever do surveys? I know they do it some hospitals. Nope.
no, well, again, because for the last year, we haven't had anybody in here because of COVID. So, it's, we're kind of like back ground zero again.
Yeah, they used to do it. They've done it at, they did it at Henry Mayo when my dad was in there. But
Yeah.
HIPAA has prevented a lot of that now.
Yeah.
The pink ladies can no longer go in the rooms and find out who's in there. It's kind of sad, but it is what it is.
Okay,
Yeah.
so let's get back on track. So this goal 11, is everybody okay with that one?
Yep.
Okay. Are there any other goals that any of the board wants to discuss? For Tim?
They're subject to updating and changing
If we need to.
if everything.
No. You're locked in.
If he gets to going too good, we can
But they're-
bar higher.
They're gonna be annual reviews, but we're gonna look at them
Oh, yeah.
as
Oh,
the day goes on. I
Yes.
mean, we're gonna be,
Well, I don't know if you've ever gone into Tim's office. He has it posted right in front of his computer screen. They're there on the wall.
Yeah.
It's a daily focus
Constantly
for him.
staring at me.
Yeah.
And some of these are also in concert with the strategic
plan.
plan that's ongoing.
Yeah.
Right. So we need to approve these then. So I'll
I make
entertain
a
a motion.
motion to approve them.
Thank you, James. John seconds. Any other discussion? Any member of the public wishing to be heard on these goals? Okay, all in favor?
I,
Opposed? All right, goals are approved. All right, so that brings us to item number 4, the item we added, the capital expenditure request for a chemistry analyzer. Could you please fill us in?
Yeah. So.
This is Rebecca Martin, who is our
Thank you.
lab manager.
So we have an older analyzer. I think Tim said it was 10 years old, but it's actually
Stay close.
and the contract is actually up in November this year. And when Abbott, anytime they renew a contract, they charge us, and then those have been, like, it increases by a lot. And it's, since I've been here, we have struggled with their service. They started with a company called Peak, so they outsourced their service. They didn't care about anything but the bottom dollar. And I can't tell you how many countless hours I've been on the phone with salespeople, and really, at one point, I stood at the lab and told them that they couldn't leave because our hematology analyzer, which was already replaced, but it's the same company that does the service, they were gonna leave us down over the weekend, and they didn't care. And I was like, no, you're not. You're gonna stay here and fix it. And we actually, my husband, who's a plumber, and George got together and figured out a way to get the thing working so that we could run QC, make sure everything was good, and keep it going over the weekend. It wasn't even their service. So I don't have a very good taste in my mouth with them. I'm probably will never be an ally of Abbott. I haven't seen a product yet where they provided. So based on that, and the fact that both of the instruments are old, the other one will be 5 years old, and in March, it's actually the one that broke down over the weekend. And it's the one that we've had to make the workhorse because the other one is so old. It ran for 4 days and we were having error after error after error, and just crossing our fingers, hoping that it would keep going so that we only had, I feel, a very minimal amount go down to Bakersfield, but it was enough, so it's an issue for maintenance because they have to go. But it did its purpose, but barely. Any longer than that, it would have completely died. So as Tim kind of touched on, chemistries are extremely important for the doctors. They're actually one of the primary revenue makers in the laboratory. When the money comes in, it's normally from chemistries. So it's a very, very critical piece of equipment. I did my research and I had a lot of input from my staff. 2 of my CLSs have actually worked with the one that I'm pushing for. I personally have not. I've always worked with Roche everywhere I've ever been. I've touched on Beckman. I've kind of seen Siemens. But Roche is the Cadillac. And you can see from when I did up the pricing, they're really expensive. They're also brand new to California, so they don't have the service built up like they should. So it's not a really great option. Ortho, Eden and George have both worked with it. But we actually had Ortho prior to Abbott coming in, and they were all pretty upset that Ortho was leaving because the service was great. They never had a problem when they were down. It wasn't a problem. They could talk them through it. Things were a lot easier. It's also a dry chemistry, which during the fire, we didn't have water. So that means we cannot run chemistries on the systems that we have now. There's nothing. They're dead in the water. With the Ortho system, you can continue to run. It's got some other great features. I know just this weekend we've spent, I want to say about $4,000 on probes trying to problem solve. This actual analyzer has a smart tip and it prevents the kind of things, the buildup and the things that ruin those probes. It changes it after every sample. So that's a huge savings. It also, we had 2 weekends ago, somebody filling in phlebotomy and they threw on a rack with a cap on. And on the architects that we have now, it crashed the probe. That's $900. It's an accident. It happens. It happens in every lab I've ever been to. But it's $900. This instrument senses that, stops, changes the tip, which is pennies, and then goes again. So it's just an overall better instrument. As far as service goes, they have 4 engineers in the area. They have Palmdale, Delano, Valencia, and LA that are right around us. That's way better than the 1 engineer we have to come from LA with Abbott. And then if we can't get him, we have to have someone from Las Vegas come. So that's pretty much my spiel. I am pushing for 2 analyzers, and the reason is because even if we get the best of the best service and the best of the best coverage, there's a learning curve, things break, there's miscellaneous things that happen randomly with plastic parts. To get a service engineer out here, if the only one available is in LA, then it's 4 hours. And then if they don't by chance have that part, it could be a whole day. So it's kind of an unrealistic thought that just because you have that service means they can get it up immediately.
So let me clarify, your recommendation is for the ortho one?
Yes.
And we would be approving the purchase of that for $348,000 tonight?
For the two analyzers at $348,000.
You get 2 for that price?
2 for
Okay.
that price.
What's the lifespan?
These actually on ortho, unlike the other 2 only gave me a 5-year service. That's kind of what they set them at, 5 years. Ortho gave me a 6. When I did the breakdowns for you, I did it in 5 years, so you're comparing apples to apples. But it's actually, they gave us a 6-year because they feel that this instrument is hardy.
Will they upgrade it? Everything changes so fast now.
The thing with chemistry analyzers is the technology doesn't really change. What changes are the tests that cartridges. And so when you get, like we do it all the time with the one that we currently have, magnesium changes different assay platforms. So they send us a new cartridge. We have to load some stuff into the instrument, and all of the instruments now are online. So it just takes that data and we can run the new technology. So the basic concept of running it is the same. It's the actual reagents gonna change.
It sounds awesome. It sounds like a.
Yeah, I'm really, I mean, Tim can attest to how much stress this chemistry has been on really the both of us, because he deals more on, he has to take the doctor side and discuss it with the doctors, because the point I'm trying to fix it, it's just an endless battle. So between the two of us, this instrument has been a real.
And I want to thank her staff, and I'm going to come tomorrow and talk to your staff. Their ability to keep that machine functioning this weekend was remarkable. I mean, they literally were the service techs. I mean, literally going through that thing, tearing it apart, you know, and changing just about any part that we had available. And so, you know, it's just, we have an obligation to give them equipment that's going to work. And again, our physicians were extremely frustrated over the weekend. Dr. Burrows, I was surprised he never did call me back that night. So I assumed you calmed him down somehow.
I got the result.
But, right. And so, you know, again, but it is critical to what we do. I mean, most of the patients that come through the ED are going to require chemistry to be done. Like I said, the lab itself was still running. We could produce all of our cardiac tests. We could produce our urines. We could produce, you know, all of our
coags, we had
everything. Yeah.
blood gases, we had
It's just the
everything.
chemistry, and that's the one that's most critical.
And we were at one point patching, we have that great radiometer that we got for blood gas, which has electrolytes on it. Well, the electrolytes on the old one have been a problem for a couple years now. So we couldn't get those up and running. So we were running stuff on the blood gas analyzer and going over it. It was just kind of a patch. We were going back and forth trying to get these results to the doctors. It was a long weekend.
Do you think it would be a good idea for us to approve that and take 348,000 away from IT?
Oh, I don't think so. I'm not crazy enough to say that.
I think you should.
Can I make the motion that we, oh, you got.
Sorry, what I was going to say is actually the number with the warranty service pricing added in is 497.
Oh, okay.
Okay.
Okay. I don't see how we cannot do it.
I don't disagree with you.
Yeah, like I said, you know, she and I talked this weekend about the possibility, because I'm looking at the numbers too. And again, going back to the challenge you're giving me, you know, it's, you know, I said, could we do this with one machine and a 7-day-a-week contract and so forth? And her answer was yes. And I think she tried to put that together here at the end. But, you know, as we talked about that, the bottom line is we've had that experience with other equipment in there. We're rural, we're remote, you know, you can't get service here.
It's gonna make us more money.
Even if you've got the contract, they can't get here. And so, you know, because we live and die by that ER, that's our revenue machine.
So,
We've got to be able to provide that service. So I agree with her.
And there are
And they made us a good
different
deal on the pricing.
yeah, they did. Also, on the breakdown that I gave you, if you look at it, the service reagents and consumables for 5 years, the Vitros, which is ortho, is actually cheaper than what we currently, because anytime you have a wet chemistry, it's got so many reagents that have to go on. Your consumable rate just goes through the roof. So it's actually saving us money in the long run from that reagent.
Yeah, and we had to have special water purifiers
Yeah, and you
to
don't.
get the water clean, because we don't have great water coming in.
That's like the wet x-rays versus the.
Yeah.
Can I make a motion that we accepted the 2 machines for the, Fred, was it,
$197,640. Where do you get that additional amount of 48?
That's on the last page of 13.
Start at the bottom, Ross, once you add in
Yeah, so
all of your
if
service contracts.
if you look at the 1 versus the 2, it's, I think it's like 8,600, but don't quote me on that. It's 86 or 80 something. Difference a year between the 1 versus the 2, because anytime you buy 2, they give you a deal.
right,
But when you buy 1,
service and
they
everything?
jack
The
up.
key to it is we're currently dealing with older equipment in the house now that really needs to be upgraded. So
Correct.
It's gonna make us more money, cost us less money.
Yeah, page 13 showed that 497 that Fred was talking about.
So that's more than what we'd set aside in the capital improvement budget, right?
we put 348 into the
Yeah,
budget.
and
Oh, did we?
This-
Okay.
Yeah, this is stretching it out over the period too.
Yeah, this
Right.
is 6 years worth of cost.
Yeah, it's not 1 year's cost.
And we have that built into the budget because our current architect takes that and more.
Yeah.
So,
This is actually a saving on the reagents and stuff.
All right.
Okay.
So you've made the motion
Motion.
for approving staff's recommendation. For the
The,
ortho.
yes,
Yeah.
whatever the recommendation is, and some of it's over a period of time or however, whatever
Okay.
they.
All right. Do we have a second?
I'll gladly second.
Do we have more discussion or questions, concerns? Does any member of the public wish to be heard on this item? Okay, seeing none, then all those in favor? Aye.
Aye.
Opposed? Okay. Approved. Thank you. Thanks for your diligence. Thanks for patching it together. Amazing.
Well, she's still gotta do it for a while.
Yeah.
yeah, it's not going
Doesn't
to.
show up tomorrow, you know.
What's the delivery? What do you anticipate? 60 days or something?
As soon as they get the money, it's a 90-day because the validation, chemistries are really difficult to validate as far as there's a lot of time consuming parts you have to validate the test. It's 90 days to get that up and going, so.
So accounts payable will get this done in 60 days? Just kidding.
Well, and just to throw another little wrinkle in there, if the lab, if we did not have our submittal for the upgrade of the building under the old building code, the lab would have to be moved indoors and it would be 9 months approval from Oshkosh.
Oh my goodness. Oh my goodness.
It would
Okay.
be less expensive because they're plumbing free.
That's the nice part, yeah.
Right.
No plumbing.
You know what I
just like
forgot to do
Consumable.
is address the scholarship program that I pulled off consent.
Okay.
We need to circle back to that. Sorry about that, folks. I pulled that off consent for 2 reasons. One, I'd like to understand our cost for this scholarship program. And secondly, just to highlight the fact that I think it's a wonderful program and that this is an opportunity for folks that want to better themselves. And there are some amazing letters of support in here. And so I didn't want it to just hide under consent. I thought it was a really terrific thing to bring attention to. But what is the cost? What is our cost to that?
Mark, do you want to address that?
I knew you were going to do that. Our cost is basically, and I think Heidi could probably explain it better than I, but what we do is that person is required to work part-time hours and go to school for part-time to equal full-time hours. And she gets a full-time paycheck.
So we do some.
Okay.
They pay for what she goes to school.
Salary. We do some
I'm sorry?
reimbursement for books. And it allows them to keep their full-time status so they can keep their
I see.
benefits and their health
Okay.
insurance. And so it kind of supports them while they're going through their program.
So no additional cost to us other than maybe books and supplies.
There's a little bit of books and supplies and the shifts that this individual wouldn't be working, we would have to fill with somebody else.
We're showing
but
an employee. Yeah.
It's kind of growing our own in anticipation that she'll work here afterwards. We're in a desperate need for RNs, particularly in the department where she works.
Right.
She's dedicated to that department, and so it's succession planning to get rid of the registry that we have in there now.
Are we gonna have to be paying $200 an hour while she's attending school to a
The
registered
one
nurse?
that's in there now is not at $200 an hour.
Okay, good.
Less than half that.
All right. Well, I would like to make a motion to approve the scholarship.
Okay. Is this online or is she going to,
She's in a bridge program, an LVN to RN bridge program.
I know, but
Some of
where,
it's online, some of it's clinicals and hospitals. It's very similar to any other clinical training program. Some is online, some's in the classroom, some is
Okay.
in the facility.
so she'd be gone a week and then work a week or something?
No, she'll work a couple of days a week and the other days a week she'll be going to school. We'll work her
Okay,
schedule and
okay,
have her
but,
school schedule.
okay.
Yeah, she's there for a week.
Time and,
In order for us to match her time, she has to work that pay period. So if she takes the whole week off, we match nothing. She has to meet her obligation before we meet ours.
Okay,
Right.
great. Well, I think it's a wonderful program. I really do. I
Do we
think
need a motion to,
I made the motion. You want a second?
yes, I'll second.
Okay. Any discussion? Any member of the public wishing to
Can
be
he,
heard?
John, can he make a motion?
I don't know, that's a good question.
I don't think
Scott,
so.
Scott, can you make a motion as chair?
If you strictly followed Robert's Rules of Order, probably not, but you guys don't strictly follow Robert's.
Fine,
rules.
I'll withdraw my motion.
No, we don't.
He was saying to follow it.
We don't follow him though.
He can make the motion.
Okay,
Okay.
he made the motion. I second.
All right. All those in favor?
Aye.
Aye. Opposed? All right. Thank you, everyone. All right, that brings us to near the end of our agenda. For director's comments, and Gene, I'll start with you.
John, I'm sorry I got uptight. As you get older, you just find trouble finding your balance. And I'm gonna try not to get older. But,
Impossible.
yeah, I'd like to thank everybody that puts up with me and works toward making the hospital better, including Tim. Thanks.
No problem.
Thanks, Gene.
I apologize for losing my cool during a meeting. I know our emotions can kind of get to our head every once in a while, and I think with me, it had been getting there for several months, but I do want the board to work together, and do what's best for the public, and I appreciate what everybody at the hospital here is saying. I know it's very trying circumstances at times, but that's all I have.
Thank you, John. Fred?
Hostility comes out because we all care about what we do. We wouldn't be doing this if we didn't.
I hope
care
you don't
about
call
what's
that
going on.
hostile, what I did.
Give it time. It's getting better. All I can say is thank you to everybody for being here. Everyone that's here is what makes this enjoyable, it's what makes this a team effort, makes our job easier, and thank you.
Thanks, Fred. Catherine?
Thank you, gentlemen, for your apologies, and I'm sorry I stepped in. It's the great grandmother in me or something. It's like, but it's just real important to me how we as one, because we're a body, conduct ourselves. And I guess as many times I've been coming to these meetings before being on the board, it's just what I've come to expect. And I just appreciate the apologies and stuff, and the compassion and passion that you guys have, but it's, yeah. So thank you.
Thanks, Catherine.
I'm not talking next meeting.
That's on record.
I'm also on vacation. So maybe
I said John will play it back.
Oh, yeah.
I appreciate every one of you. I appreciate your passion and the fact that you care about what's happening with this district. I've, on occasion, I've lost my temper as well. So I guess I challenge all of you. Let's see if we can do better at not doing that at our meetings. We care about what we do, but we certainly don't want to take it out on each other, and we certainly don't want to take it out on our staff. And if you see things that you don't think are right, then it's incumbent upon us to ask about that, but let's do it in a very professional way, and stay focused on the problem that we're trying to solve, and make that the issue. So with that, thank you all. We're adjourned, and we will meet again in a month.
Good evening, everybody. Catherine, try to speak cool.
Fred, it was so nice to have you.
It is nice.
It was, yeah. I was like, yeah. I keep thinking,